The following podcast is part of a certified educational activity titled Targeting Higher Standards in Resectable NSCLC, the Surgery-Oncology Coalition for Tailoring Care in EGFR and ALK-TKI Therapy. Access the entire activity and complete the post-test at peerview.com/RDK860. Downloadable slides and practice aids are also available.
Hi, everybody. We're very glad to have you here for this PeerView live session on targeting higher standards in resectable non-small cell lung cancer, the Surgery-Oncology Coalition for Tailoring Care in EGFR and ALK tyrosine kinase inhibitor therapy. We're very happy to have you here. I'd like to introduce myself. My name is Mara Antonoff. I am a thoracic surgeon at MD Anderson in Houston, and I'm joined by Dr. Karen Reckamp, who is a medical oncologist here at Cedars-Sinai in Los Angeles. So I'm very fortunate to be joined by such a very talented and experienced colleague, and we're very excited to jump into today's topic for you all. We have a couple of goals for the day. We want to try to augment your knowledge of the latest evidence on EGFR and ALK-targeted therapies in resectable lung cancer. And we want to equip you with the skills for developing biomarker-driven, individualized treatment plans for patients with resectable lung cancer who exhibit EGFR mutations and ALK fusions. So we're going to jump now into new needs and realities in genomically altered resectable lung cancer. We know that EGFR mutations and ALK fusions are common in all stages of lung cancer, including early stage disease. Here you can see the prevalence rates of EGFR mutations across the different stages of lung cancer. These are specifically EGFR, shown in this table, with 20% of stage 1 patients harboring EGFR mutations, 18% of stage 2 and 3, and over a quarter of stage 4 patients demonstrating EGFR mutations. We know that approximately 3 to 5% of patients with non-small cell lung cancer are ALK mutated with a similar incidence in early stage disease. I think it's important for us all to acknowledge that early biomarker testing can guide appropriate treatment selection and planning in resectable lung cancer. We know that a coordinated approach to testing among the multidisciplinary team can really ensure optimal treatment selection and planning for resectable disease. Here you can see across the figure at the bottom really kind of the pathway and the different places where we might do biomarker testing. So once a patient has an initial detection of a suspected abnormality, at the initial tissue biopsy, this is really the preferred timing for conducting biomarker testing for EGFR, ALK, or any other abnormalities, any other alterations, as well as PD-L1 expression. The patient will certainly need confirmation of the diagnosis and staging and ultimately a treatment discussion. But if the patient then goes on to surgical resection, this is another opportunity for biomarker testing if it has not been performed during the initial biopsy or there wasn't an adequate tissue during the initial biopsy. But all of these markers then guide adjuvant treatment decision making as well. We know in order to get all this information and plan care for the patients that we need effective multidisciplinary collaboration, and this can include our surgeons, our oncologists, our interventional radiologists, pathologists, pulmonologists, everyone who's part of the team, so that we can make sure that we're getting the information we need to make the right decisions for these patients with resectable lung cancer. The 2024 ISLC Global Survey on Biomarker Testing found improvements in how much biomarker testing is taking place, but we know that gaps still remain. In this survey in 2024, it found, again, improvements in the perception of testing rates compared to 6 years prior, but there continue to be substantial barriers in testing. It seemed as though about 2/3 estimated that more than half of individuals with lung cancer are biomarker tested in their country, up from only 38% in the 2018 survey. It seems that testing is more prevalent in late stage disease, maybe 63% of the time, compared to under a third in early stage. But in terms of the respondents to this survey, 43% said that they would sometimes or often treat patients prior to receiving any biomarker results. So certainly there are gaps that remain, and there's an opportunity to continue to improve how many patients are being tested prior to therapy initiation. When we think about the types of barriers, respondents to the survey identified cost, time, and sample quality, as well as access as being issues more often than awareness, with cost again being the greatest challenge. So I think at this point we're going to turn our attention toward EGFR targeted therapy in resectable lung cancer, and I'm going to turn the mic over to Dr. Reckamp.
Thanks so much. So we'll talk about EGFR targeted therapy for resectable disease. And as we saw, it's about 20% in early stage disease. I will tell you, for somebody who practices in Los Angeles, on the West Coast, we see more closer to 50% of our patients with EGFR disease. So it is somewhat location specific. And if we're not testing, we're not giving patients their adequate treatment. So that's the important thing. But what we do know, the ADAURA study was first presented in 2020, and this was a phase 3 double-blind study looking at osimertinib versus placebo. And these were patients with stage 1B, which are currently stage 2 with tumors that are 4 centimeters or more, through 3A, resectable non-small cell lung cancer, who underwent resection. And they had exon 19 deletion or L858R, exon 21 mutation, which are the most common mutations and account for about 90% of patients with EGFR mutations. They had to have brain imaging, which was negative, and negative margins, and the goal was to have a minimum interval between surgery and randomization of 10 weeks, and if they did not have adjuvant chemo, and 26 weeks if they did. So patients got adjuvant chemotherapy as per investigator on both arms, so that was not pre-specified, and then they were randomized to receive either osimertinib or placebo. And this was for a duration of 3 years. Many of the trials we've used, the immunotherapy trials, use 1 year. Many of the targeted therapy trials we've used in the past use 2 years. This is now extending that to 3 years. And there may be benefits, as we see in diseases like breast cancer and GIST, for prolonging that timing on therapy. And the primary endpoint was disease-free survival, and they had follow-up until recurrence. So here's what we see for the primary endpoint, and this was updated recently and presented at ASCO 2023. For stage 1B through 3A, there was a significant improvement in disease-free survival, and here we see the median at 65 months versus 28 months with placebo. And this is with a hazard ratio of 0.27. We rarely see hazard ratios that impressively low. And then if you look at the more advanced disease, stage 2 to 3A, we see very similar numbers and a hazard ratio of 0.23. So this is clearly improving the disease-free survival and helping patients who have resectable disease and EGFR mutation. Here we see overall survival, again, presented at ASCO 2023. And there were reasons why we thought maybe overall survival might not be improved with these targeted therapies, differing from cytotoxic or immunotherapy, which may be killing off more tumor. But again, here we see an improvement in overall survival with TKI. And again, we have a hazard ratio of 0.49, and we have 88 months versus 78 months for the patients across 1B through 3A. And for stage 2 and 3, it was 85 versus 73 months, and again, 0.49 hazard ratio. So clearly benefiting patients in disease-free survival and overall survival. Then looking at patterns of recurrence. So we do see specific recurrences in these types of patients, and we're always worried about CNS recurrence. And you see in the orange is the placebo, in the blue is the osimertinib. Most of the recurrences, though they were half the placebo, were in the lung. And you see very, very few CNS recurrences. We see 6% versus 11%. And most commonly lung, lymph nodes, and CNS. Interestingly, all of these places are places that we often then do local therapy to rescue a patient. And so those are options for patients too. What about adjuvant chemotherapy? So there's always a question. We know from the early 2000s that adjuvant chemotherapy can improve survival by about 5 to 10%. And there's a lot of lackluster interest in it, but it does help improve survival. So with those patients who did or did not receive chemotherapy, again, this wasn't randomized, this was per investigator decision, but there was similar outcomes regardless of chemotherapy received. And what about toxicity? So we're intensifying therapy, so we know that we're going to have increased toxicity over placebo. And what you see here, diarrhea, paronychia, dry skin, pruritus, those are all very common TKI toxicities, and about 47% with grade 1 or grade 2 diarrhea, very few grade 3 or grade 4 toxicities in these patients, though we know that these drugs are taken day after day and can affect quality of life even with grade 1 and grade 2 toxicities, but overall very well tolerated. So what's coming down in the pipe for us? So ADAURA 2, so the ADAURA included patients with early stage disease, but now 4 centimeters or greater, so stage 2 and stage 3. What about those with completely resected stage 1 disease? This is the ADAURA 2, and these are 1A2 and 1A3 tumors that have R0 resection, again with the common mutations, and patients would not receive chemotherapy for these tumors, and they would receive osimertinib for 3 years versus placebo. In this study, we're going to look at disease-free survival. It's really not powered for overall survival. I think overall survival would be a very, very hard endpoint in this patient population, but this is ongoing. And then there's a trial that's being done in Asia that is the Target trial, and this is looking at 5 years of osimertinib. And so, and again, there are some thoughts that increased TKI use or small molecule use may be better over longer durations for patients. So very similar to the ADAURA trial, these patients receive adjuvant chemo as per investigator, and then they're receiving osimertinib for 5 years, and looking at disease-free survival. There's actually also a group of uncommon EGFR mutations looking at this. So we know that patients with uncommon mutations do have response to osimertinib, but it's generally for shorter duration and less deep response. But this will be evaluated also in this study, which is helpful. Often these patients we don't know what to do with. And then what about neoadjuvant therapy? So we're all very excited about the adjuvant space, and in immunotherapy, neoadjuvant therapy is pushing ahead and can be very beneficial. We haven't seen as positive results from kind of the early phase 2 studies that have been published in the neoadjuvant setting for tyrosine kinase inhibitors. But these trials are ongoing, and the NeoADAURA trial, again, is looking at neoadjuvant osimertinib with or without chemotherapy versus chemotherapy alone, which would be the standard for those patients with EGFR mutant disease. And they're looking at, again, stage 2 and stage 3, and those with common mutations. And there's 3 arms: placebo plus chemotherapy, osimertinib plus chemotherapy, or osimertinib alone. And again, event-free survival and overall survival will be the primary endpoints. They'll also be looking at major pathologic response and pathologic complete response in these patients. And I'll pass it back to Dr. Antonoff.
Right. And we have already received several fantastic questions, and we want to thank you very much for those. It seems to me that these questions are broad and would be best potentially addressed after we talk about ALK, and then we can jump in to some of these questions. Okay. So just to talk about ALK after we've heard such a great overview of EGFR. So I think it's interesting how it feels like so many surgeons are aware of ADAURA, and many of them don't know the details of ALINA. But I think this is just as valuable for us to be aware of. And so ALINA was an adjuvant study of alectinib compared to chemotherapy in early stage resected ALK-rearranged non-small cell lung cancer. So for the purpose of this study, this included patients with resected stage 1B through 3A ALK-positive disease. And these patients obviously all had to be eligible for chemotherapy, had to have reasonable end organ function and performance status in order to be able to undergo surgery and any necessary adjuvant therapy. Patients were stratified by stage, 1B versus 2 versus 3A, as well as by race, and they were randomized 1-to-1 to alectinib or platinum-based chemotherapy. And then if at the time of occurrence, any further treatment was at the investigator's choice, and patients were followed for survival. The primary endpoint was disease-free survival, and other endpoints included CNS and disease-free overall survival and safety. And so here you can see shown on the left disease-free survival for stage 2 through 3A, and you can see that there's very clearly here a hazard ratio of 0.24 with alectinib shown in the blue line on the top and chemotherapy in the orange line on the bottom. And we see very similar findings if we look at DFS for stages 1B to 3A, intention to treat on the right. Again, here also with a p-value of less than 0.001, and our disease-free survival hazard ratio is 0.24. Again, with those patients receiving chemotherapy shown in orange and those receiving alectinib shown in blue. So it really, the primary endpoint here of disease-free survival definitely was shown to be substantially impacted through these analyses with ALINA. When we look at disease-free survival by a single stage, you can see 1B shown in the top left, 2 in the bottom left, and stage 3A in the bottom right. And we see 2-year disease-free survival rates shown in the table in the upper right, looking at alectinib compared to chemotherapy. And we see across these stages hazard ratios of 0.21, 0.24, and 0.25. So again, we see a substantial improved disease-free survival at our primary endpoint of in these patients who received alectinib compared to those who had chemotherapy. When we look at sites of recurrence at our intention to treat population, you can see that first bar, stacked bar on the left is alectinib. The stacked bar on the right is chemotherapy. And those individuals who had local regional and distant as well as local regional and distant recurrence is greater in each of these areas in chemo compared to alectinib. Importantly, when we look at the sites of recurrence, as shown in the table to the right, those who had brain recurrence were much more common in those who received chemotherapy. And we may not be as familiar with this as surgeons, but I know our medical oncology colleagues and radiation oncology colleagues can really attest to the fact that the location of the recurrence absolutely impacts patient experience, patient treatment, and really their quality of life. And so these CNS recurrences are a big deal, and if we can prevent brain recurrence with alectinib, that's obviously a very important factor for these patients. When we look at CNS outcomes, CNS disease-free survival in the intention to treat population, here you see those who received alectinib shown in the blue line on top and those who received chemotherapy in the orange line beneath it. And here you see that the hazard ratio is 0.22. And so this is actually quite substantial for these patients, and it's an important finding from ALINA. When we look at the ALINA updated adverse event data shown here, these are adverse events that occurred in at least 15% of the patients, with alectinib shown on the left in blue and chemotherapy on the right in orange. And you can see that the most frequent adverse events that we saw in the patients receiving alectinib was mild lab abnormalities, constipation, nothing substantial. Obviously, COVID-19 isn't necessarily something that we would be looking at in every era of these types of studies, but was relevant for ALINA. And that's a little bit different from the adverse events that we see in chemotherapy with nausea and vomiting, decreased appetite, being fairly common in those groups as well. But despite the longer treatment duration with alectinib, which was 23.9 months compared to only 2 months of chemotherapy, the overall incidence of these adverse events was really similar between the two arms. There were a few discontinuations of treatment due to adverse events in the alectinib arm at only 5.5%. This was true of 12.5% in the chemo arm. And this is really interesting given that the chemo, again, was only for a couple months and the alectinib was going on for 2 years. But the most of the commonly reported adverse events occurred during the first month of treatment with adjuvant alectinib. There are certainly other trials besides ALINA that utilized alectinib in earlier stages of lung cancer. The ALNEO study, which is shown here on the left, looked at patients with resectable locally advanced stage 3 non-small cell lung cancer. They receive neoadjuvant alectinib and then have surgery for those with non-progressive disease and then adjuvant alectinib. So this is a sandwich approach of a perioperative alectinib, and this is taken place at 20 Italian centers with the primary endpoint of major pathologic response. The Nautica-1 study also is looking at the use of alectinib, and this is for patients with resectable 1B, 2, 3A, or selected 3B cases. And as I assume many of you are aware, Nautica-1 didn't just involve patients with ALK, but really based on the patient's testing, they would end up getting alectinib for ALK or other drugs based on other molecular profiling. But regardless of what their mutational abnormality would be, surgery and pathological response assessment is assessed. We have some time now to go into discussing what we've just presented to you all, an interpretation of the data, any practical considerations for integration of these strategies into our practices. And we've received several questions. Maybe we can start with addressing some of those questions. I think some of these are obviously best answered by surgeons versus medical oncologists, but mean, perhaps we want to just jump right in. I think this first question, what should be the role of surgeons in discussing adjuvant, targeted, or other therapies with patients, is it best just to refer them to a medical oncologist before or after surgery? We probably share similar thoughts, but I think I can say, as a surgeon, I think it's an incredibly important role. I think we have to know what our limitations are and what that role is. I do not try to talk to patients about the side effects, the complications, the risks of a drug that I'm not allowed to prescribe. But I also, I think in a setting where I really maybe don't even know the data, but I know the patient might need to see a medical oncologist, at the very least, what we can do is say, this is worthy of a discussion, and then you can decide the benefits and drawbacks with your medical oncologist. But I think we as surgeons really need to understand how impactful we are on our patients, that rapport we have with them, that bond, that trust they put in us. We might not know how to prescribe these drugs. We might not know what the risks are. We may not even be allowed to consent patients for these drugs at our places of employment, depending on the specific drug and the institution and where you practice. But ultimately, our patients trust us. We have a long-standing relationship with them. They trusted you in their most vulnerable situation. And whether you think they need something in the adjuvant setting is incredibly important. And just as much as we can make an impact by suggesting to them that they may really benefit from a discussion with a medical oncologist because they may stand to have an improvement in their outcome with additional therapy, our ability to dissuade them from getting needed adjuvant therapy can also not be overestimated. And so I think we have to be very careful. I think surgeons who use language like, I've gotten it all out, you're cured, those types of kind of stories that we tell can be really problematic for patients, because we all know that lung cancer can recur, and even at the earliest stages, even if well treated, even with a high quality operation. So, I don't think anybody's asking you to be a source of doom and gloom and tell patients, you just went through this operation, but you're probably going to recur. But at the same time, I think it's a false narrative for us to say, you're cured, you don't need to see a medical oncologist. I think instead what we tell them is, we believe that we took out all the disease that we know that you have right now, yet at the same time, we have data that would suggest that patients in your situation may be able to continue to stay disease-free with certain drug therapies, and it would be really beneficial for you to talk to someone. I think that tends to be my approach, is to tell patients that you've done the hard work, you've gotten through this operation, you recovered, you did all the things you needed to do. We worked together as a team to get you to this point. Let's not have our hard work or what you've been through go to waste. Let's see what we can do to try to make sure we minimize any chance of this ever coming back. So that's kind of the role I see for myself as a surgeon and for all of us as surgeons. But obviously the medical oncology perspective in this situation is incredibly important too. I mean, do you want us surgeons to be telling patients that they should be seeing medical oncologists, what drugs they should be getting? Should we be consenting them for receipt of the drugs? What should we be doing?
So thank you. Yes, I completely agree. I think I see this as a partnership, and the majority of patients that I see who have resectable disease come from the surgeon. And so the first person they see and the first relationship they have is with our surgeon. And things have evolved over time. Maybe 10 years ago, the surgeon didn't have to think about adjuvant therapy, and saying I got it all out was kind of good enough because we had pretty poor options for patients. But now in the era of immunotherapy and targeted therapy, and the fact that we actually want to do molecular testing, and it may delay the surgery, having this partnership and having the surgeon understand that these agents are out there, that they can benefit patients, and that there may be more to their care than just the surgery is very important and very helpful to us to continue that conversation. In breast cancer, we would never think of even the earliest stage 1 patients, even DCIS patients get multimodality therapy, and it's a teamwork approach. And I think it's a relatively new phenomenon with the era of targeted therapy and immunotherapy, but it is essential for our surgeons to at least understand that more therapy is there, and that trust you build with the patient, it absolutely carries through when we see them and have to explain why we have to give them more intensified therapy.
That's great. This next question, I think, is also one for you to answer. From Sophia Bennett, does smoking history of the patient matter impact the outcome of EGFR or ALK-targeted therapy?
So overall, most patients with EGFR and ALK alterations are relatively light or never smokers. for the most part, not 100%. So for the most part, we're not thinking about that. But overall, patients who are smoking or have recently stopped smoking clearly do worse with surgery and with adjuvant therapies. But I don't know that we have that data specifically for the ADAURA and ALINA trials, partially because we have such few heavy smokers.
Perfect. Boy, we got a lot of good questions. Let's to keep going here. So, you talked a little bit about the neoadjuvant setting and neo-ADAURA, but there's a question from Olivia Turner. Currently, the targeted therapies are only approved in the adjuvant setting, but if the neoadjuvant trials are positive and lead to approvals in these settings as well, how do you envision these agents being used? Are there pros and cons of each approach? And can both be used perioperatively like immunotherapies?
So I would say, as I mentioned in the EGFR section, we do have a number of phase 2 neoadjuvant trials that are looking at pathologic complete responses and other secondary endpoints. And they really haven't been as robustly positive as we've seen with immunotherapy. So these trials are ongoing, but in cases for patients with targeted with oncogenic drivers, especially those who are light or never smokers who are not going to benefit substantially from immunotherapy. I think we're still thinking about standard chemotherapy if we're thinking about the neoadjuvant approach. And we'll have to see what these trials show us. But 2 cycles or 8 weeks of TKI therapy may not be enough to change the biology of the disease in the same way as we've seen with immunotherapy.
Terrific. I don't think I have anything to add to that. That's wonderful. This is a question that I think we were anticipating getting from Ethan Parker. Why adjuvant chemo with adjuvant osimertinib but not with alectinib, and what are the considerations for use?
So that's a great question, and it is probably a question that will never totally be answered. You could see from the ADAURA study, chemotherapy was per the investigator. When they did the subset analysis, again, selected patients, some patients who wouldn't have been able to receive chemotherapy or were too sick to receive chemotherapy who didn't. It wasn't necessarily based on stage or any kind of randomization, but they did similarly. And what you see with the ALINA's trial, they took chemotherapy out completely, and we still see a very significant disease-free survival when compared to chemotherapy. I will say that EGFR and ALK are a little bit different, so we can't necessarily compare both. Those of us who grew up in the adjuvant chemotherapy, we know that there's a survival benefit for these patients, so it's a little bit hard to think to omit it completely. In ALK patients, we know that pemetrexed-based chemotherapy is exquisitely, that ALK patients are exquisitely sensitive to pemetrexed chemotherapy, so we may be losing a little bit more benefit. These patients live for a long time, even with metastatic disease. Median survivals are over 5 years. And so it's hard to get that endpoint. And so we may not know. But adjuvant chemotherapy, I think it's still here to stay for select patients. I don't think it's going away completely. But in the ALK setting, you potentially could omit it.
Great. We have a couple questions here. I think we'll maybe jump one just that I can answer a surgical question and give you a break to maybe catch your breath for a second. Resection after induction chemo immuno can be very challenging, especially in central tumors. Should these patients be operated in high volume centers preferably? So, I think to generalize the question, since, we're talking about, patients with targeted therapy as well, if any of these complex patients who maybe in the future will be treated with neoadjuvant targeted therapies as well, I think it's an important question. As our multimodality care for resectable patients becomes more and more prevalent, patients with all stages of disease seem to be more frequently candidates for therapy before surgery. Where should they get their operations most safely, and how can that be done? I certainly speak as someone who works at a high volume center where we are very resource fortunate, and we've got a lot of support to do complex operations. I don't think it's fair to say that if a surgeon has experience working on difficult cases and has a team that's prepared to keep the patient safe, that they shouldn't be doing complex operations. And so I think, certainly it depends a little bit. We don't want people to be dabbling in something that's challenging and perhaps put the patient's safety at risk. But I'm also not going to say that every patient has to be sent to us at a large university-based cancer center, because we want to be able to help patients everywhere. So I think certainly if these cases are harder than what you're accustomed to doing, yes, send them somewhere where the resources are there and they're accustomed to it. But also we as an organization, as a specialty, need to figure out how to continue to make adequate oncologic care available to all of our patients, and perhaps to train ourselves and to train each other to really continue to grow as surgeons in all of these ways. I think there are a lot of ways to handle it. Not every patient can go to a big center, but we certainly can all improve, every one of us, regardless of where we work. Any other thoughts about that?
I don't have much to say to that, but I agree that unfortunately we'd like everybody to go to high volume centers, but that's not going to happen for every patient. So I appreciate having these meetings and training of our next generations of surgeons to become those people who are in the community centers as well as in the high volume centers.
That's great. Dr. Reckamp, can you help us answer this question? How do we justify ordering reflex biomarker testing in stage 1 lung cancer right now in clinical practice, where data are preliminary, not standard of care? Who's paying for it, and how do we get buy-in?
So I think that is a challenging question. I think at our institution we do reflex testing, and I'm fortunate for that because it also brings the fact that when the sample goes to pathology, a part of it is cut and goes to our molecular diagnostic lab. So we get results in about a week. That we can get preliminary results. And in a surgical patient, that's really important. A stage 1 patient is not a stage 1 patient prior to surgery. So that's the problem. And so justifying it, so we have a blanket that all lung cancer patients get reflex testing. I don't know, I don't have a good answer for that about who pays for all of this, but I do think with the use of now targeted therapies and immunochemotherapy, we know that patients who, especially with EGFR mutation, that receive immunotherapy and then go on to receive osimertinib, about a third of those patients will have an increase in grade 3 toxicity. Often it's interstitial lung disease. So we can harm these patients by giving them immunotherapy up front. And we've all seen those patients with ILD post immunotherapy. When you add osimertinib to that chance increases. And so because of those things and the potential harm, that is the reason why we need to do upfront biomarker testing. I think technically insurances are not necessarily going to pay for a stage 1 to get biomarker testing, and it potentially may have to wait for the post-operative setting. But I think we're moving toward more universal, all lung cancers get testing. And that going into, we wouldn't treat a breast cancer patient without knowing their HER2 and ER/PR status, regardless of whether they're going to get therapy. We are going to know that. And so I don't think this is that different. And I think we're learning that intensifying therapy helps people have longer disease-free survival and overall survival. So I think we're moving toward that. And we were far from testing everybody in the metastatic setting a number of years ago. We're getting better at that. And I think that's where we're going in the early stage setting.
That's great. These are such diverse questions, lots of great discussion. In the absence of any further questions right now, perhaps we can go on.
Sounds good.
And now we want to move on to the tumor board portion of our discussion. We're going to talk about some cases and talk about different nuances that come up in the management of these patients. And we'd love to get feedback questions from those who are here and kind of share our perspectives with you all. But I think sometimes these realistic case scenarios can really be the best way to highlight the nuances of treating patients in these scenarios. So let's talk about this first patient. This is a 71-year-old woman who's a never smoker who presented with a persistent cough. She had a fairly thorough workup, which demonstrated a 6.2 by 5 centimeter pulmonary mass in the left lung. There did not appear any nodal involvement nor any evidence of distant metastatic disease. Her brain MRI likewise was negative for any metastases, and she underwent an EBIS, which confirmed no hilar nodal involvement or mediastinal nodal involvement. She had a transbronchial biopsy of the pulmonary mass, which was confirmatory for invasive adenocarcinoma, and her NGS revealed an EGFR exon 19 deletion. Her clinical stage is T3N0, stage 2B, and you can see her CT of the chest shown here, or at least an axial cut of her CT. Looks as though the most popular answer right now is neoadjuvant chemoimmunotherapy, although headed straight to the operating room for resection seems to be pretty popular as well. What would you do in this situation, Dr. Reckamp?
So I think, as we talked about, for patients with EGFR lung cancer or ALK lung cancer, but especially EGFR, we potentially don't see the benefit with immunotherapy. Many of the neoadjuvant and perioperative trials didn't allow patients with EGFR and ALK alterations. So generally, if we gave neoadjuvant therapy, it would be with chemotherapy alone. But in this case, this is a case that's on the borderline. Surgical resection is not a wrong answer for these patients. And so it's, I think, a discussion with our surgeons and our medical oncologist about the best approach to move forward.
Is chemoimmunotherapy the wrong answer?
I think chemoimmunotherapy is not the correct answer, in part because the trials that we're basing that on, many of them did not include EGFR and ALK, and so sticking with chemotherapy alone would be the neoadjuvant therapy we would use at this moment in time.
So what about for folks who don't practice in your setting and may not have results of their molecular profiling as quickly, and so maybe there's a suspicion that this patient may have some sort of abnormality, but we don't yet know if they have an EGFR mutation. Do you wait to treat them until you have the molecular profiling? If you want to give neoadjuvant therapy, do you start with chemo-IO and then make adjustments once you have the molecular profiling? What's the right answer?
So I think that I think there's a practical answer, and I think there may be a right answer or a semi-right answer. But in a non-smoker, I think I would be more inclined to potentially send them to surgery, because our adjuvant options are very good, and what we've seen here today are adjuvant options. These are not patients who would have been included in the neoadjuvant trials. I do see that a lot of patients just blanketly get chemoimmunotherapy without testing, and I don't think that that's correct, and I think, again, it can do harm if they end up having a genomic alteration. And so I actually think that if you really don't know, proceeding with surgery or chemotherapy alone, which was a standard neoadjuvant therapy we had given in the past for a patient with no history of smoking, would be my favored way to proceed.
Terrific.
And how about you? What is your choice? What did you decide?
Yeah, in this situation, knowing that the patient had an EGFR mutation, we would very likely give neoadjuvant chemotherapy with an intent to give adjuvant targeted therapy. But we've also shown imaging of a patient where that tumor is pretty central and pretty bulky, and I can justify that they're going to need something, and this may be helpful in the operating room. But we certainly have situations where the tumor may be a little bit different in size or different in location, and we may be tempted to go straight to the operating room. But I agree, chemoimmunotherapy is not something we would do for someone who has a known EGFR mutation. Do others have questions or comments about this?
Hi, I had a question. For patients that are like stage 2 or borderline resectable with an EGFR or an ALK mutation, do they respond well to just neoadjuvant chemo to the point where you could then take them to surgery and either do a lesser surgery or be able to effectively treat it, whereas before they were borderline resectable? Or take less lung, I guess.
So I don't think we have that data for neoadjuvant. So the neoadjuvant chemotherapy trials are far before the oncogenic driver information that we had. So I don't think we have that specific data. What we do know is that chemotherapy, that patients with oncogenic drivers, especially EGFR and ALK, are highly responsive to chemotherapy. And so could that be the case? Potentially, but we don't have that same type of data as we are gaining with immunotherapy, and they generally don't benefit from immunotherapy. So these are patients who, the borderline resectable, I think we have to think twice about and think about chemoimmunotherapy. We have adjuvant osimertinib for those patients too. But I think that they also tend to have more advanced disease. Those little nodules that we kind of forget about, those 3-4 millimeter nodules, they almost always end up being more EGFR lung cancer. Great. What are your thoughts?
Totally agree. Yeah. Totally agree. I don't have much to add. We did just get a bunch more questions through our electronic system here, so maybe we can address some of those. We have a question for the original ADORA trial. Chemotherapy was given for MD choice. What's the role of chemo? What do you do?
So I think we talked about this a little bit, but I still am a believer that that chemotherapy can help to increase the cure in some patients. And so a patient who is fit, and again, our ALK and EGFR patients that we're talking about today tend to be a little bit younger. They're non-smokers, so they don't have the comorbidities of many of our smoking patients. And so I often do recommend adjuvant chemotherapy, especially with lymph node positive disease. But again, omitting chemotherapy may be fine for many of these patients.
There's a question here. It seems like neoadjuvant therapy is being suggested for earlier and earlier stages. What do you think is the direction we're going in regard to potentially all stages, 1A1 to 3A EGFR ALK patients getting neoadjuvant therapy?
So I don't think we're going to move to 1A1, and I think 1A patients are really not the right patients for neoadjuvant therapy. And if you look at and most of the data, again, is for patients who don't have EGFR and ALK. So I think you have to think about non-smokers and EGFR and ALK differently than people who have smoking histories or have no oncogenic driver alterations. And chemoimmunotherapy is here to stay, but you will know that most of those trials had a preponderance of stage 3 patients pushing that data and those benefits. And so these early stage 1, we still really don't have data to support giving neoadjuvant therapy for the earliest stage patients.
I think that's fair. Do you think that anything will change as we get newer drugs or
I think not for targeted therapy. I think for targeted therapy, and again, many of these patients, they have such high cure rates, they just go to the OR, and for many of them, that's the right thing to do. So I think that earliest stages, I don't see that changing anytime soon.
Well, we have several more questions, but we're going to move on through this case, and we will get to these questions. We promise we'll get to you shortly, but we're going to move on to our content a little bit and get back to those questions. So this patient example that we gave you received neoadjuvant cisplatin and pemetrexed. The treatment was well tolerated with a moderate response seen on imaging. She went on to undergo an uneventful robotic left upper lobectomy, discharged on postoperative day 3, and returned to the clinic 4 weeks later, found to be recovering well. So at this point, what would you recommend for this patient?
And as we've talked about, the adjuvant portion of the chemotherapy is to the discretion. This is a patient without lymph node positive disease, but with a large tumor, and those are kind of the borderline patients that we discuss. Some high-risk features may push the patient over, but it's really a shared decision making. And then adjuvant osimertinib time for 3 years is really the answer for both of those. That is the right thing to do.
All right, so we're going to continue on to the next segment. This is another case to consider. Do you want to share this with us, Dr. Rackham?
Sure. This is a 64-year-old female with presented with chest discomfort and had a negative cardiac workup. She had a CT scan of the chest that showed a 1.3 left upper lobe nodule with no lymphadenopathy on CT, and the abdomen and pelvis was negative. The patient did undergo a bronchoscopy with FNA of the left upper lobe nodule, which showed an adenocarcinoma of the lung. The PET CT shown here shows uptake in the right upper lobe nodule, and the patient had an MRI of the brain that was normal. And she went straight to surgery with this peripheral small nodule. We didn't ask that as a question, but I'll allow all of our surgeons to have 100% to say, yes, we would all take her to surgery. And did not have NGS testing prior to going to surgery. She underwent a VATS left upper lobectomy and a mediastinal lymph node dissection. And the pathology demonstrated a poorly differentiated adenocarcinoma, 1 centimeter, with focal pleural invasion and a level 11 lymph node involved. In this patient, PD-L1 was 60%, and the patient had an EML4 ALK translocation. Another stage 2B patient, but with T2A and 1 disease. So I think for this patient, the what-if variations, so this patient didn't have NGS and went straight to surgery. What would you consider, what would you need to see to think about not taking the patient to surgery and thinking about neoadjuvant therapy? Again, it probably would be chemotherapy, right. But what scenario would you want to see a patient to get neoadjuvant therapy in this case?
Yeah, I think in this case, this patient had a hilar lymph node that was involved, but we didn't know it preoperatively. So certainly if this patient was known to have nodal disease preoperatively, we would want to give some systemic therapy in the form of chemotherapy for this individual.
And what are your criteria for so in this era of neoadjuvant therapy, everybody's jumping on the bandwagon, but patients want the tumor out, and surgeons want to do surgery, right? So what are the patients that we jump and do surgery first without thinking about neoadjuvant therapy?
Well, I happen to be very privileged to work in a place where it doesn't matter how many operations I do, I get the same salary no matter what. But I think that can be, it's hard not to feel that in some ways many surgeons can be eager to get operations done. When you have a block time that's supposed to be filled, you have RVU expectations. There's a patient who wants surgery. You've got, a hammer and they've got a nail. I think in some circumstances, many of us book out quite a ways, and so it's helpful for patients to understand that there may be a bit of time until they can have surgery anyway. So getting something to start treatment can be valuable. And ultimately, I think we try to continue to remind patients that they really only get one first chance at doing this right, and that if we have the story wrong and we don't treat them the best way possible, then their chance of survival may be different. And I think that while our information keeps changing, the story is really kind of the same in that, in as much as a decade ago, we were trying very hard to explain to patients why they had to be fully staged before we would take them to the operating room, why we didn't want to take them to resection without, ruling out any regional nodal or distant metastatic disease. We really need to embrace that we're in an era where understanding their molecular profiling is just as important as knowing their stage. And I think it's that communication that's incredibly important, because we surgeons are very good at telling patients, we're doing you a disservice if we operate on you and we don't know that you have disease outside of this spot. But we aren't very good necessarily at telling them that we will be doing them a disservice if we operate on them when they would benefit from some therapy that might be better in the neoadjuvant setting. So I think a lot of it is setting expectations and providing communication and explaining to them why we would pick the more standard of care for our own selves and our family members, and that usually carries a lot of weight.
That's great. And in this case, the patient had an ALK alteration. The one question that I get a lot is, what if this patient had a MET alteration or a RET alteration or any of or a KRAS alteration? Sure. And I think that all of the oncogenic drivers that we now have targeted therapies for are all a little bit different. And I see the kind of the drivers that are kind of non-smoking related, which are ROS1, ALK, EGFR, RET, and TRK. Those I think of a little more similarly to each other than the KRAS, BRAF, MET alterations. So it's about what's the response rate and what's the toxicity of the drugs. And so when you take a drug like KRAS, we have a lot of these patients, we want to do more for them. The response rates are really in the 30% range right now with the drugs that we have available. That's not really an osimertinib or alectinib with response rates in the 70 to 90% range. And so they're really not the right drugs to be giving neoadjuvantly, potentially adjuvantly, without a clinical trial. So we have clinical trials for that, but I think that that's where they need to do. And the toxicities matter too. A drug like a MET inhibitor, incredibly difficult to treat peripheral edema, like tree trunk, lower extremities, that then come into your lungs and require thoracenteses as a regular just to treat the toxicity. And so we have to think about that too. So I don't think we're ready for prime time for every alteration to get treated in the neoadjuvant or adjuvant setting, but I do think that for drugs that are limited, have limited toxicity and have high efficacy, those are the areas we're moving in. There's a lot of questions about adjuvant chemotherapy, and I think, again, that's a question we're not going to be able to answer well. It is up to the investigator. For this group, remember that in the early 2000s, we did have trials that showed the benefit of adjuvant chemotherapy for all patients, 5 to 10%, so you are improving survival. So for those patients with higher risk, lymph node positive disease, we may be benefiting patients by still giving adjuvant chemotherapy. It's only 4 cycles, so it's a limited course of treatment, so I don't think it's going away for all patients. And there's one question to me asking about the incidence of EGFR mutations. It's just on the West Coast, we have a larger Asian population. We have a larger group of people who have not smoked. We've had laws about not smoking for longer. And so we see more EGFR patients. In a place in the middle of the country like Kentucky, you might see more small cell lung cancer and less EGFR mutant non-small cell lung cancer. So it is really variation based on smoking habits and genetics of the population.
An interesting question here. Are patients with atypical EGFR mutations more likely to respond to immunotherapy than those with the more common EGFR mutations?
I think that's a great question, and we really don't know much about the uncommon EGFR mutations. We have the Target trial that is going to be looking at those using osimertinib.
Yeah.
The verdict is still out. Those are not patients who would necessarily have been excluded from the neoadjuvant immunotherapy trials, and so those are patients where we generally don't treat them with immunotherapy if we know they have even an uncommon EGFR mutation, but the answer is not as clear in that population.
Do you use ctDNA testing in your practice now for guiding treatment decisions? And how do you envision it being used in the future?
So at this moment in time, still the minimal residual disease testing and ctDNA testing is still not, I think, where it needs to be for early stage. We generally use it on clinical trials and maybe to get a little more information, but they're really not treatment, they really don't guide treatment at this moment in time. We do know that having minimal residual disease active is worse, but what to do and whether to intensify or de-intensify therapy is not known. Those trials are the next generation of trials. So do I think we will be using it in a decade? Yes, we absolutely will. So many of you will see that in your practice in the coming years, but it's not a 2025 practice.
Great. There's a question here about pneumonectomy and what are the outcomes of adjuvant therapy in patients who've undergone pneumonectomy? Are they any different? I think certainly one of the concerns we all have as surgeons after we've done a pneumonectomy is whether any additional treatment that we give the patient could exacerbate any type of complication, cause any undue morbidity to a patient. We certainly don't want to give them any drugs that could cause, put them at any increased risk. And I think I've heard this discussion come up oftentimes for adjuvant immunotherapy and the concern after pneumonectomy of adjuvant immunotherapy in the rare circumstances where we do see some sort of immune-mediated pneumonitis or any kind of problem when we are only dealing with one remaining lung. We certainly don't want to cause any pulmonary toxicity. But for these types of targeted therapies in the adjuvant setting, has this been something that you or the surgeons with whom you work have been concerned?
I think that, obviously when patients have to have a pneumonectomy, it's always more challenging, but I'm not sure that if the patient has recovered from surgery, I don't think it dissuades us from giving further therapy.
Terrific. And a couple more questions. For this current patient with an unknown N1 node at the time of surgery and a small primary cancer, how would you justify neoadjuvant therapy? I don't think we could. I don't think we would ever imagine giving neoadjuvant therapy to that patient, although I'm a bit disappointed the patient had occult nodal disease. And I think, seeing cases like that is one of the reasons why we advocate so fiercely for really trying to appropriately stage all patients.
I would agree, and I think that in our ALK patients especially, we do see a lot more lymph node involvement that wasn't necessarily appreciated on imaging prior to surgery. ALK and ROS1, I think they often have more extensive disease, but there's no reason to give neoadjuvant therapy when you don't see lymph node disease with a small tumor.
Terrific. Well, it seems that our 60 minutes is up, so we want to thank you all for your time and your attention, and have a good rest of the day.
Thanks so much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported through independent educational grants from AstraZeneca and Genentech, a member of the Roche Group. To access all materials for this activity, visit peerview.com/RDK860.